my biggest wish would be the mother to meet the the baby. The mother to meet the baby. I think that to me is the most difficult thing to comprehend. She now is 2 months. I'm not even living with her in the same house. I took her to my brother's place. So, and the mother is still in the hospital. Even she's now, they're bonding so well with my in-law to an extent that I'm scared I'm gonna lose the baby.
I have 3 girls, and he's the only boy, and he's been very supportive for the family. Camille plays soccer, and by the way, he always scores in St. Mary's. And what I wish for him is that I wish him good health, I wish him recovery, and that's why I've started this journey of taking him to Israel, because I know I want his bones back, I want his life back, and I wish him very, very good health as a mother.
Well, first thing, I would want to encourage people, especially mothers, because we are the ones who stay with our children most. Like you see, for my baby, the only thing he was complaining of is fatigue. I just got home and he told me, "Mami, nimechoka." And because he had the fever and the running nose, I decided to take him for a checkup. I would want to encourage every mother to make it a routine, you know, just to take your kids for checkup, even if it's monthly, because after that, it's better waichukue mapema than staying with it for very long. So, and then after it is picked up, I would also like to encourage our doctors or the healthcare fraternity to be open and transparent with us. You know, like for me, I was told from the beginning, BMT is the definitive treatment. So as much as we're giving you chemo, but the desire is that we have it done, and it is not done in Kenya. So you're given options of where to have it done. I would want to encourage our hospitals, if there's a way we can assist in getting the bone marrow transplant done here, or even getting the donors, because another challenge we have now is getting a donor for the bone marrow transplant. I'm told there's a way we can have people volunteer, donate, like the way we donate blood, you know, we can have people donating for bone marrow, and it is kept in the banks.
People just care about the money. They just want to make money out of bad situations like the sickness. And that's why you find like you have an insurance, but you do not know when these guys will take off. Immediately you show them the bill. So just revamp the entire health sector, and have government take better part of the health system. I think that would really help, because again, an average Kenyan is not able to pay for the hospital bills in Kenya. We are even told, actually, with our condition, I was told if I took her to India, her bill will be 3 million or less. Yes. So just, I don't know what they'll do, but just revamp it so that government, some of these things do not just fall into, I think the issue is it's run by private institutions or something like that.
In fact, I was discussing with my fellow colleagues, and I was telling them in Kenya now, whatever, you can see a lot of money being swindled. With that money, we can use it to put up a good specialist hospital for cancer patients, for sickle cell, and other chronic. We will do something and will save a lot. We are now heading out of the country. I'm not the only one. When I was at the Ministry of Foreign Affairs getting the permission, I saw a very long queue. Everybody's going to India. Everybody's going out with their children for the sake of looking for treatment. We are taking a lot of money out of this country for normal sickness.
Why is healthcare not free? Technically, healthcare cannot be free. Why is it not free? I know the government says, you know, we want to provide free healthcare. There's free healthcare for under 5s or free healthcare for so and so. This term free, why is healthcare not actually free?
Health as a service cannot be free because there are costs that are necessary for its production. There will be human resources, the doctors and the other healthcare workers. They need salaries. There are resources that are required, hospitals. The building themselves require to be maintained, to be built. There are inputs like the drugs, like the other non-pharmaceuticals that go into producing healthcare. So healthcare, where we agree that is a basic human right, there are costs that are necessary in its production, and therefore someone must pay for those costs. In this regard, with my take on this one is that the basic health services, which we are calling universal health coverage, I consider them really basic human rights, and are best internationally, they are best paid for through a taxation, through the government.
What are these basic health services that you are mentioning? Like, I know it will differ with facilities, but there are those basic components or basic services that somebody should be able to access in a health facilities. What are these that you are making reference to?
When the Ministry of Health Kenya has not defined the package, I strongly believe that there is a committee actively doing this. But what is consumed by 60–70% of citizens would be considered as basic infections, common injuries, maternal and children services, dealing with the common ailments of public interest like tuberculosis, like HIV, like malaria. Those should go into that basic package. And this basic package, we could start as a country with a small package that we can afford given the resources we have, but over the years extend the scope and the depth of this package so that we can cover at least 70–80% of the common ailments that, and medical condition that our people have. Into this basic package, we also need to have prevention as a very important package, because we know as a society we cannot treat ourselves to healthcare. We need to bring in the prevention arm and only deal with the persons who unfortunately fall through the cracks of prevention.
We see a very big difference between the cost of healthcare in the private sector and that in the public sector. Why is this so? Because you may find in the private sector a procedure or medicine is even 100 times more the cost as is in the public sector. Why is there such a very big difference in the same country or even in the same county, the same location?
I'd like to take it at two levels. First is the motivation for the two sectors. First, we know that in the public sector, most of the cost of providing care in terms of the staffing, in terms of the building, a lot of the infrastructure, and the drugs are subsidized by the government. As a result, the cost that is necessary to maintain this system is far much less than the private sector. In the private sector, 100% of the inputs that are required to provide care must be generated by the private institution. In addition to this, we also need to remember what are the motivation of these two sectors of service delivery. For public sector, is predominantly giving service to the mwananchi. In healthcare, in the private sector, the greatest motivation why people go into private is a profit motivation. So the markup, the surplus, is what drives the private sector. I would wish to quickly add here that going forward, there would need to improve this situation by bringing a common denominator. How do we measure the value that the client gets, whether they go to public or to private? We know the public, a lot of the time the queues are long, the waiting time is long. You may also understand that the time spent with each patient is limited sometimes only to 3 minutes, because this clinical officer or this doctor has only 7 hours in a day, and he has 100, 200 people to see. And as a result, quality of care inevitably goes down. In the private sector, they may have fewer people, but we know the tendency is to ask more tests, give more drugs, and generally make as much money out of each episode as it's possible. This is natural. You look at cesarean section in a public institution, it will generally be about 20,000. But when you go to the private sector, this cost can go as high as up to $500,000. And putting all factors in place is unreasonable. Short, I would say, is unreasonable because the doctors who are doing these procedures in the public and private hospital went to the same medical school, trained under the same professors, are using the same procedures, and most of the time, they're using the same, very similar inputs into it.
It could be even the same doctor in the public sector is the same one operating in the private sector.
Exactly. In the morning, he would do procedures in the public sector, and in the afternoon or in the night, he's doing procedures in the private hospital. Yet the cost is sometimes 100,000, 100 times more. Is unjustifiable. But because we have not set the boundaries that for this diagnosis, this is the outcome that is expected, and this is the cost that is expected, it becomes difficult to be able to measure them, the outcomes, because it's unreasonable. Kiambu is 20,000 for a cesarean section. You come to private hospitals, upmarket private hospitals in Nairobi, it's 300,000. It's 400,000. Same doctor. You are in one hospital, that information is locked there and cannot be seen. So when you go to a hospital B, then the same tests that had been done in hospital A need to be repeated all again at your cost as a client or at your cost as an insurer. The other thing is also the private sector is that for one reason or another, they do not allow insured people to go to public hospitals. They want them to go to private hospitals. And these private hospitals are charging them 2 to 3 times the same price they would charge for somebody who is paying cash.
Can we assume that cost is commensurate with quality? That if I pay this much amount of money in the private sector, then I'm equally getting quality or value for my money, as opposed to going to a public facility and I pay so little and then I feel like I haven't gotten quality.
Unfortunately not. But on the other side, the myth that the public have been fed is that the more you pay, the higher the quality. And if you look at the indicators that hospitals or healthcare facilities compete on, I would call them cosmetic indicators, because they compete on which facility has more beds, which has bigger doctors, which has more X-ray, which is more colorful. All these things have no basis on the outcome of the patient. The key thing is that the patient came, and when the patient comes to us, finally, there are only 3 main jobs, core jobs. I would like to call them core jobs. One, the patient asks, how do I get better? The patient is asking for diagnosis. How do I know what's my problem? Job number 2, the patient says, okay, now that the diagnosis is known, how do I get better? So treat me is the next job. And the final job that's usually most of the time is hardly done, is how do I prevent me from ever falling sick or getting to this condition again? So you see, most of the money and time is spent only in the first 2 jobs, diagnosis and treatment. And sometimes diagnosis is not done properly. And that's why this country and many other countries are suffering because of medical misdiagnosis or medical errors. And medical errors occur when we miss the diagnosis. The moment we miss the diagnosis, everything else we do is not useful to the patient. It's waste. Because once we miss the diagnosis, all the tests we order are not useful. The drugs that we prescribe, at best they are placebo. And at worst, they can actually aggravate the patient's condition. And if we order a surgical intervention, it is also will cause harm than in help. So the diagnosis is key. But finally, we'd like to talk about health care, not medical care, because there is all this confusion between health care and medical care. And all the money and all the talk and all the funding is talking about medical care. Medical care is only required when nutrition has failed, when prevention interventions have failed, our immunization did not work, and our social systems are failing. So medical care is only required, is a rescue. in the continuum of healthcare, because people who are healthy are productive, are happy. And that's where we want to go. But we cannot get to healthy, productive, happy people when we only concentrate all our money in medical care. We need to look at population healthcare in totality.
How then can we make healthcare affordable for you and I? As a mwananchi walking into a health facility and I want certain services, how can it be made such that I don't have to pay out of pocket and incur catastrophic consequences because of this out-of-pocket expenditure, and that I'm able to go to a facility, get the services, and at the end of the day, I'm able to pay for it, or an insurer is able to pay for it without me also having had to pay hefty premiums for the same?
It's difficult for a country like Kenya, where the majority of the people naturally work in the informal sector. As a result, if asking people to get money out of the pocket, I think is the worst form of payments we can get. It's inefficient, it delays care, it obstructs care. So the best method is for the government to collect this money, pull it into a ring-fenced account, and so that when the citizens are unwell, they can go to seek care in the nearest place possible without the fear of catastrophic cost. Where are the health facilities situated? They are usually situated at the convenience of the provider, where the doctors, where the clinical officers can access easily. The parking are designed and set aside for the providers, while the patient and their relatives need to suffer looking for parking. Sometimes the hospital may be on a road that doesn't usually have public transport. It is just inconveniencing to the client. I think this is the only industry that I know where the center of operation is not the customer. We walk to a health system, and each department you have to register, and you are treated there. If you need an additional service, you need to register in the next division, and you have to navigate the health system alone. If you're in a hotel, imagine you sit down and the person comes and you say, I want water, I want this meal and this water and this maybe wine. Then they tell you, oh, for water, you will need to go to that building over there. You drink your water, then for your food, you need to go over there. Then upstairs, you need to go for wine. And then downstairs, you need to go to the garden to get your salad. And then each of these places are giving you a bill. How often would you visit such a hotel? If there is a cost involved, the mother may delay what would have been treated as an outpatient pneumonia, and the patient can complicate and may need now very expensive diagnosis, very expensive treatment, including ICU, and this is a loss because the outcome will not be as good, and the cost incurred will be tremendously increased.
What is the best approach, in your opinion, towards achieving affordable, accessible, and quality healthcare services, which is actually the pillars or what constitutes universal health coverage? In your opinion, how should government stakeholders approach this so that we, as wananchi, we as the common citizens, are able to benefit and get value for the taxes that we pay?
We must shift our healthcare delivery system, how we pay, who we pay, and what we pay for. We should pay for a bundled service. Let me give you an example of what happens when you go to a hotel. You're hungry, you walk in, you're given a menu. And from the menu you choose based on what you want to eat and the cost, because you can already see it beforehand. And when finally you've eaten, one bill is what you're given, you pay, and that's it. Let's go to the health system. You walk in, there is no menu of what they are able to give in that health facility. It is not known. In addition, it is also...
If it's not known, it may not be there because they put a charter of available services, but sometimes when you go to the lab, they tell you, we don't do this test because you don't have A, B, C, and D, or we don't have this drug because of A, B, C, and D. So they may have it there, but availability of that particular service is something else altogether.
Yes, and what still is that most of our major hospitals, they design the business model is that bring whatever disease you have, will treat you, which is not true. Now, when you do try to do that, the overhead costs go through the roof. And that's why the cost of care is very high, because we do not limit ourselves to a certain given menu that we become proficient in. So our proficiency goes down. Our cost, admin cost goes through the roof because we have a lot of idle capacity. We have a lot of equipment, very expensive equipment, that are used 10, 20%. All this because we are working in a small niche. I'm particularly impressed that we looked at Cuba as a country, because the Cuban health system is what we need. The Cuban doctors who came, I would appreciate if they came and helped us to transform our health system from what it is now to a population health approach, where each facility or each unit is given an X number of population, of households, that they will be held responsible for. Compare this. If you had letters to deliver within the CBD of Nairobi, would you use a 22-wheeler truck to distribute those letters, or you'd use a motorbike? You probably get a few guys on border guys, get them the letters, they'll do the job one morning quickly. You get a 22-wheeler, it will displace all cars in the road, it will cause a lot of jam, it will use too much fuel and cause too much chaos. And that's what happens when Kenyatta starts immunizing children. We must delineate the functions that are of a tertiary referral hospital from the functions that are primary health care. You notice that in Kenya we have private sector is on the side, only handling medical care. Public sector is also divided into two, actually into three. There is the prevention, which is done by public health officers and other people. Very little budget, if any. There is the medical care, and then there are parallel programs. We call them either parallel programs of disease of priority, or donor-funded programs.
Moving forward, what is the best approach to make sure that at the end of the day we have quality, accessible and affordable healthcare, which is actually the model behind universal healthcare coverage? What is the best approach that government or the stakeholders should take so that as a population, as wananchi who's dependent on some of these services, we are able to benefit?
We need a system that is delivering value, that is delivering the outcomes that are important, that matter to the client at the lowest cost possible. The current system is that if you are efficient as a hospital, you admit patients, you're able to deal with the issues within 2-3 days, and you send them home, and they are happy. What will happen is that your wards will remain on half capacity or 20% capacity. You will not make money, because the system rewards the people who keep patients long, who take long to make diagnosis, who do 10, 20 tests to make a diagnosis, who treat patients using 3, 4, 5 different types of procedures and drugs, and people who sustain illness. Those are the ones the system is rewarding. We must pool our resources. Whether it is within an organization or using a government system, we must be able to do. That's terms of funding. But the payment, we need to pay for a bundle. The issue of paying for inputs, I think this is our Achilles tendon. This is a bottomless pit that no one can fill.
The cost of healthcare continues to be a pain for many parents, for many relatives, for many families, some of whom have been driven into poverty or into selling their property in order to meet the cost of healthcare. It continues to be an expensive affair in the country or outside the borders of this country. And that's where we wrap up this episode of Health Digest. I've been your host, Dr. Mercy Korir.